Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you to the Malaysian Society of Otorhinolaryngologists and Head and Neck Surgeon for the invitation for me to talk today. So I'll be talking about diagnostic evaluation in obstructive sleep apnea. So this is the overview of my presentation. So obstructive sleep apnea is characterized by three main symptoms. So these cardinal symptoms are snoring, apneic spells, as well as daytime somnolence. So back in those days when I studied obstructive sleep apnea, there were only a single pathophysiology being described, and this revolves around obstruction of the upper airway, be it from enlarged tonsils or enlarged turbinates. So we all know that when we go to sleep, the pharyngeal tone decreases, and even a minute obstruction of the upper airway tends to be accentuated. So when these patients goes to sleep, a partial obstruction of the upper airway will present with snoring. And when this obstruction progresses and becomes a complete obstruction, there will be minute hypoxia and hypercarbia, which then in turn stimulates the respiratory center, causing arousal, and the patient will eventually wake up and gasp for air. So when the hypoxemia and hypercarbia reverses, the patient goes back to sleep, and the cycle of obstruction, hypoxia, hypercarbia, and stimulation of the respiratory center occurs over and over again throughout the patient's sleep. Yeah. So, but we all know that the current thinking is different. So nowadays, because of the vast research done on the pathophysiology of the obstructive sleep apnea, we now know that there are so many other factors that come into play. It's not only about upper airway anatomy, but there are also non-anatomical factors. For example, high loop gain, low arousal threshold, and reduced muscle responsiveness that now contribute towards the development of obstructive sleep apnea. So the complexity of the different patient phenotypes, for example, the alcoholic, patients with obesity, elderly patients, warrants a comprehensive guideline on diagnostic modalities in the management of obstructive sleep apnea. However, for the time being, we are still in the very initial phase of such development. We have some bits and pieces of the puzzles already put in, especially now we are able to screen and diagnose obstructive sleep apnea confidently, but however, we still lack some of diagnostic modalities to guide individualized treatment in patients with obstructive sleep apnea. Therefore, you would see that there are a lot of diagnostic modality or even protocols, different protocols for different centers in managing patients with obstructive sleep apnea. So if we talk about screening questionnaires, so what are the screening questionnaires that you can use if you have patients suspected with obstructive sleep apnea? So the best questionnaire for you to use is the Stop Bang Sleep Apnea Questionnaire. It is very simple, easy to utilize, only 8 questions. And if you kind of forget these questions, you can just go to MedCalc, is available. If your patient score 3 or more, then this correlates with a positive level 1 PSG study. So the Stop Bang questionnaire has shown the greatest sensitivity and specificity out of all the other questionnaires described in research. So the sensitivity is up to 94.9% and specificity of up to 82.3%, and this is being shown by large population prospective based trials. So there are other questionnaires if you're interested to read. There's also the GASP questionnaire, and then the more elaborate Berlin questionnaire, and also the Epworth Sleepiness Scale. So basically the Epworth Sleepiness Scale is less utilized for screening, but it is useful as a repetitive measure to monitor treatment monitoring. So now let's talk about the polysomnography. So obstructive sleep apnea was first described following positive findings on the polysomnography. This is way back in 1965. Yeah. So the polysomnogram is basically continuous monitoring of what happens during sleep. Yeah, so we've got so many parameters going on. You've got the electroencephalogram, the electrooculogram, the electromyogram, the electrocardiography, and you've got the pulse oximeter, you've got the impedance belts, you've got the airflow sensors, and probably sensors for movement, sensors for sleep position. You can go on and on. So with a wide array of parameters, even in a full sleep study, you can have all these parameters being recorded. Yeah. So, and additionally, in a full sleep study, it can be an attended study in which a healthcare practitioner or a sleep technician comes and see what happens when the patient is going to sleep, what movement is going on, whether the patient is having an apneic spells or not. They score your sleep prospectively as the study goes on. So in contrast, we have a different type compared to the full attended sleep study. There's a limited type in which you can have only a few parameters being recorded. So minimum, you can have the thermistor, the pulse oximeter, the microphone for snoring, and then the impedance belts, as well as the electrocardiography. This is for a limited study. So this limited study can be attended or automated. If it's attended, someone scores it. If it's automated, then the patient sleeps with the machine after the healthcare practitioner hooks it up onto the patient. So this is the setting that we have in our department. A limited unattended PSG is not great, but it's useful in some of our patients. So we choose our patients carefully. This is how we do it. We have a good flow chart, and we've got contraindication tables. So if the patient fulfill any of the contraindication, the patient should go for a full PSG. Remember, a limited PSG unattended is only meant for patients with high clinical suspicion of obstructive sleep apnea, and is not useful if the patient has significant cardiorespiratory comorbidities, as what is being elaborated in the contraindication tables there. So we look at many parameters in the polysomnogram. So some of the parameters are available only in the full sleep study. For example, stages of sleep, because we don't monitor the EEG in a limited study, so we can't say for sure which stage of sleep is the patient in. And but in a limited study, we do see whether the study is reliable or not. Mainly, we look into the total recording time, as well as if we can see any evidence of detached sensors. If there's a lot, then this means that this study may not be something that is reliable. So when you're looking at the polysomnogram, what is most important is you want to be able to see whether the patients have obstructive apneas or hypopneas. So since its first description in 1965, the definition of apnea has never changed. So apnea was defined as a complete cessation of airflow. That means airflow obstruction of 90% or more, which occurs at least 10 seconds or more, and it is associated with an arousal. The definition of hypopnea, on the other hand, has evolved, where the criteria is now more strict to diagnose hypopnea. So, based on the AASM manual for scoring of sleep and associated events published in 2012, and I've checked the recent one in 2020, it's still the same, in which hypopnea is defined as a drop in nasal airflow, which is more than 30%, that occurs for a duration of 10 seconds or more, and it is associated with either a drop of more than 3% in the oxygen saturation from the baseline, or associated with an arousal. So if the patient fulfills this, then it is counted as an hypopnea. So throughout the night, if you're doing a limited PSG, the machine will calculate the number of apnea and hypopnea events that occurs throughout the night, and then what happens is it will be calculated against the total number of hours of the recording duration. So if the patient scores less than 5, this means that the patient has no obstructive sleep apnea for an adult. If the patient scores more than 30, this means that the patient has a severe form of obstructive sleep apnea. So we also do look at other parameters too to see the severity. For example, the average oxygen saturation and the minimum oxygen saturation. If you wish to be more precise, you may use other parameters, for example, the RDI or the respiratory disturbance index. So what do we look for in the clinical assessment of the patients? Basically, we take a thorough history and physical examination because we know that obstructive sleep apnea can give rise to a lot of complications, and it has got other associated comorbidities associated with it. So we even have a pro forma that we use to make sure that all these history and physical examination is being carried out. The next thing that I wanted to touch today is regarding the body mass index. So there's been a lot of speculation, many variations in assessing body mass index. And of course, we need to know that there is a specific Asian criteria for body mass index in which the cutoff point for overweight and pre-obese is there for the Asian criteria. It is less than the Western population. So do please take note. The cutoff point for overweight for the Asian population is 23 kilogram per meter square, and there is this pre-obese category which starts at 25 kilogram per meter square for the Asian population. This is because the Asians have shown to have higher cardiovascular comorbidities, even presenting with a lower body mass index. So in the clinic, this is what we do. We see the tonsils, we grade the tonsils, we look at the tongue. So the tongue is the main important factor in patients with obstructive sleep apnea. The tongue acts as a safety muscle, yeah. So it protects you from having obstruction when you are asleep. So we look at the tone of the tongue, we look at the size of the tongue, whether it's bulky or not, whether the patient is macroglossia or not. And we look at the space that the tongue is in. We see the lower jaw and the upper jaw, whether the lower jaw is small, micrognathia, or the patient has retrognathia when the lower jaw is displaced posteriorly. Or if you look at the upper jaw, if the palate is small and high and arched, this means that there is less space for the tongue to sit in, and therefore can potentially cause obstruction during sleep. So bear in mind, when we are assessing tongue mobility, we mainly look at the Friedman tongue position. It is different than the Malampati score, in which when you assess the Malampati score, the tongue is protruded out as compared to the Friedman tongue position. The tongue is within the oral commissure when we are assessing this. So in the recent years, there has been a lot of attention and research on the tongue mobility as a good predictor of obstructive sleep apnea, and how it can be used to direct future treatment, especially if we're talking about surgeries like release of ankylosing or even oral and myofascial therapy. So in the subsequent slide, I'll be showing you a simple guide on how you can assess tongue mobility, and keeping in mind that tongue mobility is divided into assessment of the anterior tongue as well as the posterior tongue. Okay, so you have seen here foramen distance, the interincisor distance. You ask the patient to do this, is more than 50% of the comfortable mouth opening. This means that the patient has a normal anterior tongue mobility. So for the posterior tongue mobility, we look at the different parameter, which is what we call the LPS. So LPS is also known as the palatal suction. So when you ask the patient to do the lingual palatal suction, and you measure the inter-incisive distance. So the inter-incisive distance when the patient does the lingual-palatal suction should be more than 30% of the complete mouth opening. So if it's less than that, this means that the patient has a limited posterior tongue mobility. I will talk about this more in detail. If you are interested to read the full paper, you can read the paper by Kamako in 2000 and published in 2015. It's a very nice read. So we assess the Friedman classification of the patient. This is very historical. We used to do a lot of this surgery, soft tissue reduction procedures, uvulopalato-pharyngoplasty, and the Friedman classification, which is inclusive of the tonsil size and the Friedman staging, tells us whether this is successful or not. So next we're moving on to molar maneuver. So we do this a lot in our clinic. So we use the endoscope to see the airway both at the level of the velum, the level of the oropharynx, the level of the tongue base, and the level of the epiglottis. And it tells us how restricted the patient's airway is. Of course, this is during awake, and we would emulate the events that happens during sleep when we ask the patient to do a reverse Valsalva, or the patient is asked to emulate the sound of snoring. So in this example, you'll be able to see that the patient has a velopharyngeal collapse. Yeah. So we'll see at other examples how we use the Muller's maneuver. So the next example is this patient who has a concentric collapse, yeah, at the level of the pharynx. This is another example of a Muller's maneuver being done when this patient has a tongue-based collapse predominantly. And this is the last example of a Muller's maneuver in a patient with epiglottic collapse. So you can see the epiglottis is retroflexed posteriorly and it's occluding the airway when the patient does the reverse Valsalva. Talk about drug-induced sleep endoscopy. This modality of investigation has gained popularity in the recent years. It has been used to direct soft tissue treatment to a patient with obstructive sleep apnea. It has also been used to evaluate patients who have failed certain modalities of treatment, like surgical treatment. So what happens in drug-induced sleep endoscopy is we perform endoscopy in patients who are asleep. But this sleep is pharmacologically induced. So we give hypnotic agents such as propofol and a bit of painkillers like fentanyl, and we perform the endoscopy like what is being done in the clinic during Muller's maneuver. So we then grade the severity of obstruction that happens at different levels of the upper airway. For example, at the level of the velum, level of the oropharynx, tongue base, and epiglottis, and looking at the direction of the obstruction, direction of collapse, will give us an idea of what soft tissue reduction surgery to do, or what kind of procedure that the patient needs to have this critical area of obstruction addressed. Yeah. So another potential application of drug-induced sleep endoscopy is using the fundamental frequency of the snore that is produced during that investigation. So we have found that in patients with unilevel obstruction, for example, the patient only has collapse at the velum or only has collapse at the epiglottis, they produce a different frequency of snore. So we have found a significant association between palatal or oropharyngeal obstruction as compared to epiglottal obstruction. So the epiglottal obstruction produce a low frequency snore, while the palatal or oropharyngeal obstruction will produce a snore which is at the mid frequency range. So this is also a potential application whereby the drug-induced sleep endoscopy would be able to help us in locating the critical sites of obstruction in patients with obstructive sleep apnea. This is what's new. So what is lacking? I've talked about some diagnostic modalities that would be able to tell us whether the patient has anatomical kind of obstruction or a non-anatomical kind of obstruction. But this requires a full polysomnogram, and this is something that is lacking in many parts, many hospitals in Malaysia. We can't afford to perform full polysomnogram for all of our patients. But if it's available, it's something that is very interesting because we are now able to segregate our patients to different palm categories. So palm 1, palm 2, A and B, and palm 3, in which we are able to predict and direct the treatment modalities to the patient even better. So I think this is something in the future, and is something that's really exciting for us to look forward to. So as a conclusion, I think we all know that obstructive sleep apnea is a prevalent disease, and as far as the evidences are for now, the current diagnostic modalities are able to screen and diagnose obstructive sleep apnea, and we still need more research for future applications to direct treatment suitable for patients with various pathophysiologic phenotypes of obstructive sleep apnea. With that, I thank you.